Okay, so next we're going to move on to Unit 2B. This really discusses assistance with labor, augmentation of labor, induction of labor, some of the things that we're going to do to try to help labor continue to progress, preferably in a vaginal way. Okay? So first we have to differentiate between induction and augmentation. So induction, all right, is going to be the stimulation of uterine contractions before the start of spontaneous labor. So before labor has begun on its own, we're going to go ahead and induce or introduce the laboring process. So if, for example, we have a preeclamptic mother and we want to go ahead and attempt a vaginal delivery, we might induce at 37 weeks, 38 weeks, and not let her go to term. Now, with that being said, induction, because you don't have that normal release of oxytocin, you're interrupting a natural process in this induction procedure, you are at increased risk of heading to a C-section or having to use instruments during your delivery in order for that to occur. It's also associated with an increased use of epidural. Anecdotally, Pitocin is more painful than natural oxytocin. So using Pitocin creates more pain for the woman. She might require more epidural and pain relief measures than what she may have been able to do on her own without the use of Pitocin. It also puts the infant at increased risk of NICU admission. Now, I'm not sure if it's just the induction itself that does that or if it's the reasons that we choose to induce with, blood sugars and blood pressures and whatnot. So, however, with that being said, policy standards set out by leading institutions and backed by evidence-based practice, the guidelines by AWHONN, by your neonatologist organizations, by your American Academy of Pediatrics, by your American Academy of Gynecologists and Obstetricians, all of these are going to say that the recommendation is that induction not take place before 39 weeks except when there are other risk factors. And that's what I'm talking about as far as risk factors, putting babies into NICUs, twin delivery, maternal high blood pressure, those sort of things. When you have those circumstances, then yes, we want to induce. But if we want to induce because you're sick of being pregnant, that's not a reason to add in all of these other risk factors that come with induction. So that is induction, introducing of labor. Augmentation. So augmentation is a little different. Augmentation is after the labor process has already begun, but we need a little help. Like we have started to dilate and we petered out. Our contractions were doing their job, but now they're very, very ineffective. Most usually we're going to see this for hypotonic uterine dysfunction, which is just that. The uterus is hypotonic, it's not effectively contracting. And we're most commonly going to do this in the form of medications, i.e. Pitocin. So before we can do any of this, okay, before we can induce and then augment if needed, we need to evaluate whether or not the body is going to respond to all of these mechanisms that we're going to try to do. So first we're going to talk about the Bishop score. So for an induction to be successful, it must be what you will hear referred to as ripe. The ripening of the cervix. Our cervix is ripe. Okay, well, what does ripe mean? Is it like a peach? Is it like a pear? Like, I don't know what ripe means of a cervix. A ripe cervix is nice and spongy and bouncy, okay? It's going to be short, it's going to be centered, it's going to be partially dilated, it's going to be partially effaced. An unripe cervix is going to be longer, it's going to be tightly closed. Remember back on our 2A where we talked about that fingertip when we're talking about cervical dilation, just that fingertip on that Honey Nut Cheerio, okay? That cervix is not doing too much. Posterior, remember our Braxton Hicks contractions are moving our uterus anterior. We want baby to shoot out. If our uterus is still tipped back, so will our cervix, right? It's part of the uterus. And so if our cervix is posterior and firm, that's not a cervix that's going to respond very well to induction methods. So we're going to look at dilation, effacement, station, cervical consistency, that's the softness or the firmness, and the position anterior, posterior. In order for us to have a successful vaginal delivery, we need a Bishop score of 8. If we have a 6 to an 8, the cervix isn't quite ripe, and so we're going to do the other things to ripen the cervix prior to induction. Now, can we augment prior to induction? Absolutely not. Okay. You need your cervix to be ripe and ready to open, or opening, before you start that uterus contracting. You're going to build up a ton of pressure and you're going to create a ton of problems if you stress that baby, stress that fetus, and you don't have an outlet. So how do we ripen a cervix? How do we get it to a Bishop score of a 6 to an 8? We use medications. So cervical ripening methods, these are prostaglandin preparations. Remember, what do prostaglandins do? They soften the cervix. Okay? They're going to help thin things out. In order for us to even do this, we need a Bishop score of at least 4. Okay? Otherwise, if we don't have this, we're not going to have a successful vaginal delivery. We need to look at a C-section for alternative delivery methods. Prostaglandin E1 preparation, it would be a misoprostol or Cytotec. Cytotec is, it's not approved, FDA approved for cervical ripening, but it's used very, very frequently. It's very common. We're going to start with a low dose of 25 micrograms, and we're going to repeat that every 4 hours. It's it's inserted vaginally without lubricant, and it's a tablet placed right up against the cervix. Without lubricant because it starts to dissolve right away. Potential complications of the use of Cytotec or misoprostol include increased risk for uterine tachysystole, increased risk for hyperstimulation of the uterus with fetal heart rate changes, and increased risk for uterine rupture. So these are definitely not without risk. The E2 preparations, which ripen the cervix and stimulate uterine contractions, include Cervidil. Again, this is 15 milligrams. This is inserted and placed vaginally. It can be removed after 12 hours, or if active labor, or if we see tachysystole or abnormal fetal heart rate changes. And Prepidil is, that's the one here on the top. That's in a syringe. A 0.5 milligram in a 2.5 ml syringe. It's administered through a catheter attached to the syringe and again placed right up against the cervix. The great thing about those two medications, especially more so the Cervidil, is it can be removed, whereas the Cytotec dissolves. Now I did ask about the Laminara. It is a possibility that's out there, but it's not one that is commonly used, at least in this area. So what we're doing here is we're going ahead and mechanically dilating and ripening the cervix by stimulating the release of endogenous prostaglandins. So if we put some pressure on that cervix from the external side versus the baby putting pressure on that cervix from the internal side, then perhaps we can encourage the release of mom's own prostaglandins to go ahead and complete the process. So one of the things that we can do is called a Foley balloon, which is a catheter balloon. It's literally a Foley catheter inflated with sterile water and pressed right up against the cervix. This is the one time where you actually want the Foley catheter to go into the vagina versus the urethra, excuse me. There's these hydrocopic dilators. So these ones, like this Laminara that's here, they absorb like the natural fluids that are in the cervix, and then they enlarge, and then they put pressure on the cervix. So Laminara is a natural preparation made from seaweed that's been dehydrated. And then there's also Lamisil, which is a synthetic dilator made from magnesium sulfate. So you insert these obviously without rupture of membranes because the cervix is still closed, and you're not going to want them to just absorb amniotic fluid and do nothing. But as they absorb, again, they are going to cause dilation and release of mom's own prostaglandins. Now, what is most common is going to be the amniotic membrane stripping. So this is typically done actually in the provider office. It can also be done inpatient, but the provider is going to separate the membranes, the amniotic membranes, from the wall of the cervix. So remember, you can get like a fingertip in if we have any kind of like dilation to one, and the provider is going to use sterile gloves because we want to keep this as clean as possible. This is not a rupture of membranes, but still we don't want to introduce any kind of infection. The provider is going to insert their finger through the cervix, and then they are going to rotate their finger in 360-degree motion and actually then create